So welcome to the weekly HOPE Zoom call. We're glad you're here. We're excited to have Dr. Vadim Gushchin from Baltimore's Mercy Medical Center. And just a few things as we begin. Please remember that we are not licensed physicians. We do have one here today. We're excited for that, but we cannot give medical advice. We're glad you're here. We're happy to offer some insights and guidance and things for you and your physician team to think about, but we do not provide medical advice. There may be some graphics or information that's scary to some people today. We have reviewed it with Dr. Gushchin, and so we think you're going to be okay with it, but we find that it can bring up some emotional distress sometimes. That said, please keep in mind, you can hide your camera. You don't have to share your image, and you can change your name. You don't have to share that, but it can be technically difficult for some people to do that. And so your identity and health information may inadvertently be shared. So we apologize for that, but that is necessary for us to point that out. And then finally, by participating, you do give permission for your likeness to be shared with patients, caregivers, or other physicians. We do record these for the benefit of our patient and caregiver population, so that they can benefit from these Zoom calls. And so please keep those things in mind. Additionally, as we move forward, we found these have become so popular that we have to manage it to a fair degree. We'll go for an hour and a half today, and we'll keep it to that time frame. And so we will limit it that way. But we encourage you to use chat features to talk to other folks on the call. And if you feel like connecting with people that you see on the call, you're welcome to send emails to zoom@pmppals.net, and we'll do our best to make those connections. And lastly, we'll say, we don't want you to feel like you have to be here the whole time. We are here to provide information for you. This is recorded and will be posted later, so participate as much or as little as you would like. And before we jump in, I will remind folks that you can go ahead and email your questions to zoom@pmppals.net. We're aggregating the questions there and presenting them to Dr. Gushchin. And if we have time, we'll open up the floor toward the end of the call. But we're going to try and keep everyone muted so that we can all participate and listen in. So with that, I'm going to go around real quick and introduce the PALS team. I'm Chris Piekarski, the president. I'm a 16-year survivor of appendix cancer. Adele, would you like to say hello?
Sure. Hi, everybody. I echo Chris's comments. Highlight of my week as well. I'm the vice president of our PMP PALS board, and I'm a 9-year survivor.
Thanks, Adele. Charmaine, how are you today?
Hi, everybody. I know most of you. I'm Charmaine in Austin, Texas. I was diagnosed 23 years ago and had my CRS HIPEC 11 years ago, and I'm doing great.
Thanks, Charmaine. Well, and again, so Dr. Vadim Gushchin from Mercy Medical in Baltimore has joined us. He is the director of the Peritoneal Surface Malignancy Program. He is partners with Dr. Armando Sardi, who was my surgical oncologist, and we're super happy to have him here today to talk about ostomies and its relation to cytoreductive surgery and HIPEC. So how are you today, Dr. Gushchin? Thanks for joining us.
Thank you very much. Thanks for inviting me. I'm fine. Thank you for introduction. I'll introduce a little bit, tell the audience a little bit about myself too. I actually got into cytoreduction kind of venue by chance. I did my residency in Washington Hospital Center, as you know, where Dr. Paul Sugarbaker practices. And it was impossible not to be involved in the topic of cytoreduction, especially when I wanted to be a surgical oncologist. And it is a challenging area because of the knowledge that is required from the physician, and because of the technical abilities that you need to demonstrate during the surgery. And it took me additional probably 5-6 years of training and maturing as a surgical oncologist to start doing the operations that we're talking about. So, I joined Dr. Sardi at Mercy 15 years ago, and we were partners since then. And for a long time, we have a research department that allow us to improve our outcomes, to learn more about the disease and how to make the patients' lives better. And one of the influential papers that we published this year is on the topic of ostomies in patients that we sometimes need to perform during cytoreductive surgery and HIPEC. I think it's an interesting topic, and I've witnessed kind of transition in thinking from 20 years ago, when almost everyone would get ostomies when I was a resident, after this surgery, to now when it's a pretty rare occurrence. So we summarized our experience at Mercy, our 25 years experience at Mercy, joined with Dr. Sardi, and we presented it first at a meeting and then published as a separate paper. So that's the background why I'm doing this presentation and what I have to say. I structured it the way to give you some insight into surgeon's brain, how we think, how we make decisions during the surgery. Because for you, I believe this is one of the most important questions when you wake up after the surgery. Do I have an ostomy? And maybe a second question, whether all the tumor is gone. I think the sequence is different, but definitely those two are on the top of your minds. And you will see that the answers are related. So do you see my presentation?
No, not yet.
No, not yet. I need to share the screen, right?
Yes.
There you go. All right.
There you go.
So so that's basically the first slide for the presentation. Introduction slide, and so surgeons make decisions based on anatomy, and when we're talking about ostomies, we're talking about anatomy of the colon. So those are sketches. I hope they're not frightening. And you see the stomach on the very top, and the small bowel in the very center. And as a frame, you see colon, the ascending colon, transverse colon, descending colon, and the rectum. Is my cursor visible?
Yes, it is.
Good. And there is a little appendix here, the source of tumors that give peculiar pseudomyxoma peritonei syndrome. So, so if we've eliminated everything except the colon on this slide, on this part of the slide, and you see again ascending colon, transverse colon, descending, and the rectum. So the rectum is confined into the bony pelvis, which is a very uneasy place to operate, because you don't see things very well there. The angle of your gaze is quite different. If you look at the rectum straight on, like you can hold it in your hands, so it's easy to manipulate. It's easy to make precise cuts and sutures. it's not so easy deep in the pelvis. You need long instruments. You need to know how to get there. So it's technically it could be quite challenging. Again, it's unfortunate for surgeons' anatomy because they were constrained with these bones of the pelvis. So if you look at the male pelvis, you'll see from the side, this is the front of the pelvis, this is the back of the pelvis, this is bony, this is the end of this spine. There is no spinal canal anymore. And this is the rectum, and we, for technical purposes, divide it into high rectum, medial rectum, and low rectum. And the peritoneal cavity, that's where the tumor is usually gets accumulated in patients with peritoneal malignancies, is in front of the mid portion and the high portion of the rectum. The low portion is typically hides pretty low, as we say, below the peritoneal reflection. It means that the tumor that involves peritoneal carcinomatosis does not get there. So we'll contrast to rectal cancer surgery when the tumor starts inside the rectum. Surgeons who operate on peritoneal carcinomatosis try to get rid of the tumor that is outside the rectum. And this is one of the major points that we try to make in the paper, that you cannot apply the same rules and the same data that you accumulated for patients with rectal cancer. You cannot apply the same rules when you operate in patients with peritoneal surface malignancies, because you have different objectives, and the operation is done with different principles in mind. So this is on the examples of a female pelvis. You see the same picture, the same cut of the pelvis. This is the back, this is the front. This is peritoneal cavity, and it's filled up with deposits of tumor, which is in yellow. And this is one of the difficult places in the pelvis between the uterus and the anterior rectum. It's called space of Douglas. If you look through the operative reports, you may see this name, space of Douglas. This is, again, this is this triangular shaped, from this perspective, triangular shaped space between the uterus and the rectum, where the tumor usually accumulates. It grows there, and you need to get it out. And the way to get the tumor out, the easiest way, is to remove the uterus. Even if there is nothing wrong with the uterus, you just need to get there. And sometimes you need to remove part of the rectum, because again, there is no other way to peel all the tumor from bottom of the rectum up. So, and that's where we need to not only resect the uterus, for example, remove the uterus, but also remove part of the rectum. It is much easier to deal with nodules that are on the left side of the slide, because you have direct access to it. It's more or less on the surface. It's in front of you, and you can peel it off, the bowel, peel it off from creases between the bowel. So it's just easier to operate. You don't always need to resect part of the bowel to get these nodules out. So how can we, if we need to resect a part of the bowel, there are two ways to deal with the ends of the bowel. Either you can put them together, and it's called anastomosis. Sorry, the S got lost here. But so this is anastomosis. You see the parts of the colon removed and sutured together in the middle. And the other way to deal with the ends is to leave them open. So you leave them open as an ostomy on the colon, and you actually shut them close, the part of the bowel that goes into the rectum. So ostomy or anastomosis are two ways to deal with ends of the resected bowel. If we remove part of the, if we do the ostomy on the with the end of the ostomy, when the end of the ostomy is in a colon, it's called a colostomy. It's a large bowel, and the farther along the colon you are, the more the output from the ostomy resembles normal stool. It's formed, it's not liquid, and the amount of the stool is not that much. It's kind of the same amount as the you would have without the ostomy. If the end of the ostomy is the small bowel, it's called typically ileostomy or a small bowel ostomy. The output from the small bowel could be quite high. We typically advise to keep it below 1 liter a day, but it's it could be liquid, and most of the time it's liquid, sometimes with particles, but it's never just real stool. And patients with ileostomies could lose a lot of fluids during the day, and they won't even notice it, and they may get dehydrated very easily. Chemotherapy is difficult to get through if patients have ileostomy. It is possible, but it requires a lot of work. And if you really want to go into fine technical details, the ostomy could be end ostomy, when you have like a tube sticking out of the skin, just one lumen of the tube, or loop ileostomy, when you have the ostomy that brings up the bowel contents, and the other part is just is non-functional, but for the purpose of convenience, it's brought as a loop. So now I think that's the most technical jargon that I'm going to use, but that's the basics of the ostomy. So how do we make a decision whether to do ostomy or anastomosis? Well, I would tell you that surgeons do not like ostomies. And in this, we are quite on the same page with patients. We don't like ostomies because, first of all, internally as a person, I feel like I'm a loser anytime I give an ostomy to a patient. I lost something. Patients do not like it, and you can, no matter how well you prepare the patients for that they're going to have ostomy or possibility, they're never happy to have an ostomy, except with a few exceptions. So, and if there is an opportunity, and sometimes it's not very easy to perform an ostomy, believe it or not, especially when there were previous surgeries, the patient had previous surgeries, or the abdominal wall is thick, it's not easy, or patients had a lot of tumor removed from the bowel. It's swollen. It's just technically it's very difficult to do an ostomy, and taking care of the ostomies may be challenging as well. So whatever it takes, we try to consider an ostomy. However, when there is nothing to work with, when there is no much bowel to connect together, if there is no bowel at all, if you remove all the colon or all the rectum, there is nothing to connect, so you can't perform an ostomy. The other big thing that dominates our brain is whether the connection will leak, and we'll talk about this a little bit later, but it's a huge disaster to have a patient with leaking anastomosis, and some of you may know that it's a real surgical emergency, and patients may require additional surgery, additional procedures. They may require additional admission to the intensive care unit, and definitely their hospital stays prolonged. The further treatments are delayed, and patients may die. So anastomotic leak, the leak when you connect to pieces of the bowel, is a big surgical problem. And through the years, we began to accumulate so-called risk factors when patients are likely to have an anastomotic leak. And it turned out that if you lose a lot of blood during the surgery, the risk goes up. If the surgery lasts more than 4 or 5 hours, the risk goes up. If the patient's malnourished, they don't have enough nutrition and lost weight, a lot of weight after the surgery, before the surgery, the risk goes up. If we have to go all the way down to the low part of the rectum, the risk goes up. If the patient had previous radiation to the pelvis, the risk goes prohibitively up. So as you see, a lot of risk factors apply to patients who undergo cytoreductive surgery. Cytoreductive surgery is long. It lasts, the majority of cases last more than 4 or 5 hours. The patients are malnourished. They may received a lot of chemotherapy before. So typical patients have 3-4 factors, risk factors for unstable or leaking anastomosis. So naturally, surgeons may be scared to perform the anastomosis in the patient's best interests. So this is a slide to recap what I just said. We sometimes avoid performing anastomosis connecting the bowel when it's technically not possible to do, or when we anticipate that the risk of leakage is very high, and the benefit of having normal bowel movement overweight the risk of anastomotic leak. You see on this picture, it's fairly a good representation when, as you can tell, most of the stitches are holding, and only in one corner there is a small leak. This is enough to make patients sick, to cause peritonitis, and sometimes patients die from this little hole when other stitches are still holding. there is a technique called protective ostomy, when we divert the bowel contents away from the anastomosis, which is somewhere, for example, here, right? We removed part of the colon. We connected the colon together, but we still give patients an ostomy to let the connection heal before patients resume normal bowel movements. So it is this technique, the protective ostomy, typically in the United States is protective ileostomy, is used when we perform a resection of the rectum. The lower in the rectum the anastomosis is, more commonly we use this technique. We give this connection time to heal, and it usually takes about 6 to 10 weeks to understand whether the connection healed or not, and we check it with various X-ray techniques, we typically are able to reverse the loop ileostomy or protective ostomy before patients, hopefully before patients need to undergo chemotherapy after the surgery or adjuvant chemotherapy. And this technique of protective ileostomy was very prevalent, at least when I was training. Almost everyone would get protective loop ileostomy. Surgeons felt that HIPEC and cytoreductive surgery in HIPEC is a very high-risk procedure, and it is unreasonable to do anastomosis in the rectum without this protection with ileostomy. As you see, up to 96% of the cases would end up with protective ileostomy. However, we also know that to close the ileostomy, a second operation is required, and you can get into complication even with smaller surgery when you close protective ileostomy. And in fact, some patients do not have ileostomy closed for some reason and end up with a permanent ostomy. So this is our paper published this year, where we reported that out of almost 900 cases of cytoreductive cases, 243 patients had resection of the rectum with rectal anastomosis. In the minority of them, we performed protective ileostomy, and every 10th patient, 31 out of 243 patients, had ostomy when no colon was left to perform the anastomosis. So with this push to perform anastomosis without any protection, our patients had only 1.2% leak rate. This is considered to be low. I know that every patients with leak is a disaster and a tragedy, but taken as a whole, as a group, I think it's a fair trade-off to perform these surgeries with this low risk of anastomotic leak and high probability of the patients waking up without a bag. So and this slide demonstrates how we close the protective ileostomy, how it could be reversed. You see this two lumens of the small bowel. In a surgery under general anesthesia, we typically remove this, we call it mobilized, or separate the lumens of the small bowel away from the subcutaneous fat, and suture the bowel back together, and the ostomy is closed. And we perform endostomy only when this type of surgery could not be done. And as a side note, as my last slide, I would say that again, we do not enjoy when patients end up with an ostomy, especially with the endostomy. It requires special care. I think that the majority of patients end up doing quite well with caring for the ostomies. Nobody, I think, enjoys it, but almost everyone becomes proficient caring for them, for the ostomy. They can swim, they can bathe, patients have normal sexual life with the ostomy. I do not advertise the ostomy as a good endpoint of the surgery, but if patients have to have it, life goes on for them too. So I think I would stop here, and I welcome your questions on this topic and any other topic I can help you with. Thank you.
Well, Dr. Gushchin, first I want to say, I mean, it's clear you're also a teaching professor. I mean, this is a great anatomy education that we're getting here today. So thank you very much. It's really fascinating. I know we've got some questions to go through, but I actually wanted to touch on a couple of your points. So 16 years ago, when I was seeking care, I actually went to see Paul Sugarbaker at Washington Hospital Center. And for the benefit of our participants today, Paul Sugarbaker is widely known as the father of the HIPEC procedure, bringing that procedure to North America and spreading it around the world through talented surgical oncologists like Dr. Gushchin. So we're very grateful for Dr. Sugarbaker and his work. But I went to see Paul Sugarbaker, and he had a very aggressive approach necessarily in those early days. And then I went up to St. Agnes in Baltimore, where Armando Sardi was, and I chose him as my surgeon. And it was because he had, while he was very practical and said, we will remove any organ necessary, he also said, we're not going to remove organs as a matter of course. And so I picked him because he had such a great style. So it's interesting to see this paper come out and demonstrate that extra bit of care is, scientifically okay too. So I think that's great. But I wanted to connect some of those dots for folks. Yeah, so with that, we can go into the questions. But again, thanks for such a great lesson.
Sure.
Adele, do you want to go through some of the questions?
Sure. I'll try and hit on the ostomy questions first. So one that just came up in the chat: how long after having an ostomy is reversal possible? We know of one patient in our community that had a reversal after 10 years.
Well, I believe that every case should be taken separately. I do not know what the reason for the ostomy was in this case. I would say that sometimes it's 5 years ago, we were about to publish our case series on ovarian cancer in the European journal. and the paper was rejected on the basis that our ostomy rate was low, and for them it meant that our surgery was incomplete. For some surgeons, it's just the way it is. If you have to have set reduction for ovarian cancer, I know that a lot of gynecological oncologists, just as a part of the course, do and colostomy, and that's probably the typical scenario when the ostomy stays in for like 5-10 years and nobody actually questions whether the patient needs an ostomy or not. But a more typical patients in more typical patients, the ostomy could be reversed in 4 to 6, from 6 to 10 weeks after the surgery. So that's the amount of time that one needs to heal the connection between the rectum secure enough to know that that's it, we're out of the woods.
No, thank you. These questions might not relate to an ostomy, but could you comment on any advances in the last 5-6 years for a patient that has had previous treatment?
Previous cytoreductive treatment?
Yes, previous cytoreductive and HIPEC.
So it is difficult to comment on without knowing the specific type of the tumor, for example, the situation that we're talking about. Most of the advances happen in small chunks. So, for example, we know better that patients with appendix tumors, low-grade appendix tumors, could have second and third and sometimes fourth operation, and it's still reasonable to do that because the outcomes are as good as after the first operation in those patients. So, for example, it's one of the lessons. And then we learned that surgery still is important in the setting of ovarian cancer recurrence that used to be typically treated with chemotherapy alone. We learned about different maintenance chemotherapy, again, in ovarian cancer. There's big advances on that. So that type of advances I can comment on, but it's difficult to say in general. You need to kind of be more specific. We learned, for example, that in colon cancer, prophylactic HIPEC with oxaliplatin doesn't seem to work, and we changed our approach on that one. We stopped, for example, using oxaliplatin. We're looking for new drugs to use during HIPEC, or not doing HIPEC at all. So those are major advances that I can come up with.
Thank you. Another question, could you talk a little bit on treating PMP when it goes to the small bowel? What are the treatments? What are the side effects?
Right.
And is the treatment worse than the disease?
So it is a very tough situation when patients present with a lot of small bowel disease. As many of you know, sometimes, most of the time, I wouldn't say most of the time. This is our most common stop sign for surgery when the small intestine, small bowel is involved. Sometimes there is nothing we can do surgically, nothing we can remove surgically. However, there is a technique that formalized fairly recently. It's called visceral peritoneectomy. So peritoneum has two components: the component that is on top of muscles of the abdomen, or retroperitoneum. It's you can easily peel it off the muscles. And if you get into the muscle a little bit, no big deal. You stop the bleeding and you kind of correct your course. You cannot do that on the small bowel, because if you're a little bit off, you injure the small bowel and you need to repair it. And it's if there are a lot of repairs, patients again may leak as any anastomosis can. And the more repairs you have, the higher the risk of leakage. So that's why we don't do typically peritonectomy on top of the small bowel. And recently we learned how to do that, not on the small bowel itself, but on the mesentery, which is a fatty layer that contain blood vessels that go to the small intestine. It's a very tedious procedure. Last week I did about in a patient with the tumor involved 2 meters of small bowel. I faced a choice whether to remove this 2 meters, and the patient would have been left with a lot of diarrhea and a very poor quality of life, or we spent 5 hours peeling off this this layer of tumor of the mesentery, and it ended up to be worth doing it because the entire small bowel was saved. But again, it's tedious procedure. You really need to put some time into it, an effort, and if you're a millimeter off, you can cause injury to the bowel, and it kind of the risks of the procedure go up. I would say that it's still a big problem, involvement of the small bowel. We still cannot do much if the entire small bowel involved in mesentery and the bowel itself. We can do sometimes a better job clearing the tumor of the mesentery, not and we don't need to remove the small bowel. And if some of you know that the group in Basingstoke in England performed about 10 small bowel transplants for patients with PMP. It's a tour de force. I applaud them. It's just exploratory surgery. It sometimes lasts about 20 hours. It requires bowel and abdominal wall and liver transplant at the same time. But that's kind of the extreme that we sometimes go, because we are very frustrated that the small bowel is a sticking point for us as a surgeons.
Yeah. Are there any clinical trials specifically related to the small bowel?
We're trying to open a clinical trial on, as you probably, some of you know, bromelain, a substance that hopefully may dissolve some types of the tumor, like pseudomyxoma, on top of the bowel, and make it possible to remove the deposits. This is only our plans. We still haven't started the phase 1 trial with bromelain because of the COVID, unfortunately. But that's probably the closest I can come up with.
Okay, and then related to the trials, how does a patient get their name on a list for a trial?
So far is the best way to do that is through your physician. We're a pretty tight-knit community, and we're aware of what everyone is doing, especially in the centers that who do this type of surgery and research regularly. I can give you an inside information that I don't recall that anyone would hold the patient intentionally and not providing the information in the trial, or kind of dissuading patients to go another institution to join the trial. At least I never seen or heard such an occurrence among my colleagues. And if there is a trial, I would rather send patients to another institution to join it. So to recap, I would advise that the physicians is your best resource.
Thank you. Another question, does low-grade mucinous adenocarcinoma ever warrant systemic chemo?
Well, ideally not. We do not think that, as a guideline, we do not think that there is a role for systemic chemotherapy before or after surgery if complete set reduction is achieved. However, you know that there are patients who either had a recurrence that could not be removed, and they're just left living with their tumors, and they have obviously an urge that something needs to be done. And not because we have great insight in chemotherapy. Sometimes why not? Let's try. I'm not proud of it, and nobody is, and nobody is touting it as a good strategy. But sometimes we're all humans, and we're sometimes forced to make this decision. And as a rule, in this case, we choose something with low profile of side effects. Mm-hmm. And typically it's a Xeloda or Avastin or other drugs. Again, I don't recommend it as a rule, but once in a while, either our medical oncology colleagues or ourselves, we kind of forced to when we don't have any other choice, we resort to this semi-voodoo recommendations. I'm not proud of them, but it happens.
That is great insight. Thank you.
I'd say, patients are grateful for having options, Dr. Gushchin, and at the end of the day, right, care is the care that we seek and that we want, at least in the United States, right? That's an opportunity that we have. We might have to seek out different physicians on our care team to provide the care we're looking for, but those are choices that we have for ourselves. I want to take a moment and do a bit of a commercial for PMI, but first I want to show something. So when I went and had my HIPEC at St. Agnes, I actually wrote on my stomach a little note for Dr. Sardi. I thought it'd be worthwhile to show this because the night before I was marked up. I hope you can see my cursor for the potential of having an ostomy, right? Here's my diagnostic surgery, the scar from that, but I was marked up, and I joked with the nurse and said, hey, can I go ahead and leave a message for the surgeon, she said, sure, why not? So, and Dr. Gushchin, I understand that Dr. Sardi includes that at the front of many of his presentations. Yep. So, a fun little thing to share, and you know, we make the best of these situations. Make the best out of a tough situation for sure. But with that, I also want to remind folks how they can stay in touch with us and how we can support you through this journey. We're here today on the HOPE Zoom call. They've become incredibly popular. I'll remind folks, if you have questions today, you can send the chat. We are seeing those. That's working great. But you can also send an email to zoom@pmppals.net, and we're happy to answer your questions there or make sure they get asked today. We can connect with you and send you a bare bottom bear, just so that you feel support and love, and remember that you're not alone, even though you're fighting a rare cancer. If you have questions throughout the week, if you would like referrals to friends, just email info@pmppals.net. That's another way we can support you. If you have questions about medical terminology, Arthur Rettig is a retired pediatric surgeon and also a PMP patient. He's happy to answer these questions and help get you on the right track with our complicated disease and treatment. Our most popular program is the Get Well Cards program. You'll notice Misty Price is on the call today. She manages that program, and we strongly encourage you to send an email with dates of when you'll be in the hospital or when you'll be home, so that Misty can rally the card writers and send you a wave of love that you'll never forget. And finally, we encourage you to send an email to starterkits@pmppals.net, and we have a great little kit that includes stuff you're going to need on the journey: disinfectant, some chapstick for if you're doing chemotherapy, cards that say, "Hey, I have to jump to the front of the bathroom line if you don't mind," and explains a bit about the disease. Yes, so some helpful stuff and some wet wipes, which you're likely to need too, and a little notebook for taking notes when you go on your doctor's visits. So send an email to Starter Kits. We'll be happy to send that free of charge. All that said, we would remind everyone we are a completely donations-run organization, and we would humbly ask for your support so we can continue this work. None of us here are paid for this. We actually all donate as board members and volunteers. So please consider going to pmppals.net. And there is a donations page. You can donate through PayPal. You can even donate just throughout your normal course of the day. If you go to smile.amazon.com, you can register PMP Pals as the organization you support, and we'll get 0.5% of all your spend on Amazon, which I think nowadays is going up and up for all of us. So we'd appreciate if you did that. Yeah, so with that, we'll happily turn back to some questions for Dr. Gushchin.
Yes, we've had some more questions come in. We have a patient that has had an end ileostomy since January 2017. Question is, will that get reversed if there's a second CRS HIPEC?
Well, if there is enough colon to connect it to, it's technically possible to reverse. And actually some surgeons, and I know Paul Sugarbaker used to do that too, they intentionally leave end ileostomy at the end of the first HIPEC, anticipating that it could be a second one, and that could be a chance to reconnect. Again, I'm not saying that one approach is better than the other, and definitely we sometimes use similar logic. The point of my presentation is that it is possible to do such anastomosis in the pelvis safely after CRS HIPEC. And so it is an option when you have kind of, if it fits the situation to use.
Okay, along the topic of a second CRS HIPEC, what are some medical conditions that might prevent somebody from being a surgical candidate for another CRS HIPEC?
So I usually surgeons are simple people, so I try to simplify things when it comes to indication for surgery in 3 positions. Number 1, is the disease in such states that needs an operation, a second operation. So, and it's typically a recurrence of a pseudomyxoma or ovarian cancer, sometimes, rarely, colon cancer that could be removed. If you can remove all the visible disease and do it with minimal harm to the patient, that's number 1 indication. So the second component is if the patient is fit enough to undergo surgery. So if it's the best test is an eyeball test, as I say. When you walk into the patient's room, and look at the patient, you get about 80 to 90% of what you need to know whether the patient is a good candidate or not. And that's why personal exams are so important in today's kind of situation, when we get a lot of requests from patients on either online consultation or Zoom consultation. Believe it or not, I cannot explain how you make a decision whether the patient is a good candidate or not just by looking at and touching a real person. And for example, if the patient has a recent heart attack or a stroke, or nobody can care for the patient in the first couple of months after the surgery, those are important considerations that we take in mind. And the third component, if there is a surgical team capable of doing second or third surgery, they have experience and they have a philosophy in place to treat this patient. So those are 3 components that I usually go step by step. If the disease is right, if the patient is fit, and if we can do it.
That's great. And so most patients get their CEA levels or other tumor markers checked. Is that also another indicator? Is there a point where that might indicate significant recurrence?
So tumor markers are helpful adjuncts in making decisions. We wrote a couple of papers on this topic. We never make a decision to do surgery or not to do, or whether the patient has a recurrence or not, based on tumor markers alone. Almost never. Tumor markers is our adjust our anxiety level about recurrence. So if there is something questionable on the CT scan and the tumor marker is up, the chance that patient has a recurrence is higher, let's say this way. Interestingly, high-grade tumors, high-grade appendix tumors, frequently recur without any elevation of tumor markers. So the more aggressive tumor is, less helpful tumor markers are.
Can lamin develop into high grade in a patient that had low grade and had recurrence rather quickly after surgery?
So it's another fascinating question. Again, the paper this year that we published actually addressed some of it, of this question. So it turns out that, sorry, different deposits of the tumor in different places in the abdomen may have a different type of cells from high grade to low grade. So in the same patient at the same time, in different parts of the body, grow tumors of different makeup. What may happen, maybe we treat successfully the low grades, and high grades, for example, stay unchecked, and that's or patients don't get any additional chemotherapy, or something else happens. So that's most likely scenario why patients develop seemingly a progression from low grade to high grade. I know it's maybe a complicated concept, but on the surface it may seem so, but the mechanism of this is not quite clear.
Okay, thank you. And on the topic of a repeat CRS HIPEC, is there an optimal time period between the first and the next one, assuming the patient's eligible?
Well, I think it's a judgment call. You really want to know that you have a good well, agreeable tumor, let's say this way, agreeable tumor to work with. So the tumor comes up, grows back within a month or two, and you know that you did a good job doing such a reduction. There is something off here. Maybe you're missing something, and I would be very reluctant to jump into conclusion and offer patient the surgery. However, if it happens within like a year or two, it is I have a better feeling offering patients additional surgery. And there is no good guidance from the evidence-based part of the medicine. So I think we have to do some research on this one. But as a general rule, that's how we make decisions.
You know, this brings up a question for me, actually. You know, what is how much license do you have, Dr. Gushchin, in choosing different chemotherapeutic options? I've heard of patients where, you know, recurrence within a year happened, and then different chemotherapeutic agents were used with success. And I know that, right, we have some chemosensitivity testing that we can do. This is not approved by the FDA, but I think many of us feel that directionally it gives us some information, the chemosensitivity tests. But how much license do you have in choosing different chemotherapeutic options? And I know particularly we have a question asking, are there
about mitomycin C, right?
Yeah, about, yep.
Yeah, I saw it too. Actually, I have full authority on choosing the drug. If I feel that mitomycin C is not the right drug, I would certainly choose another one. About 10 years ago, or actually 12 years ago, we went through a phase where we every tumor would be tested through different commercial companies, through chemosensitivity assay and chemoresistance assay, the two different. It's a little bit tricky to see the difference, but there is a difference. And would use that would guide us better. I don't think that it made any difference, and many other groups confirmed that it's probably did not make any difference. So now we're trying to make a more intelligent choice based on the genomic makeup of the tumor. You probably heard companies like Tempus or Foundation One. Some genomic pathways, mutation in genomic pathways, shown to render patients tumors more or less susceptible to certain types of drugs. So that's another way of choosing it. And a third way, and most common way, I would say in our practice, is to based on common sense. If it didn't work first time, you'd better change something. Again, we're simple-minded surgeons, not much imagination there, but to us, it makes sense.
One more question. What is the role of radiation or even proton therapy, right? We've got the Proton Center there in Baltimore. Radiation, we rarely hear of this treatment modality, but I don't know if like low pelvic disease is no longer surgically operable.
Radiation is a type of a local therapy, local regional therapy, like surgery, right? We can use local therapies in one part of the body. So you're right. If there is a critical recurrence that causes obstruction, for example, or other like pelvic pain, it makes sense to consider local therapies such as radiation. Otherwise, I haven't seen anything but great destruction from radiation, to be honest with you. It's a gift that keeps on giving. You cannot undo the results of the side effects of radiation, and if side effects for surgery get better with each year, right? Side effects from radiation, if that happens, gets only worse. So that's why radiation is definitely part of the armamentarium in certain situations. Rectal cancer, prostate cancer, there is no doubt about that. But in peritoneal surface malignancy, there is very few situations when that is helpful. And my general advice, and I rarely do that, my general advice, if some patients with, if you're a patient with peritoneal surface malignancy, peritoneal carcinomatosis, and you're advised to undergo radiation, I would almost automatically get a second opinion. I'm not saying that it's wrong. I'm telling you that I would take a second good look on this advice, and definitely discuss it with your surgeon who is experienced with peritoneal surface malignancies. I've seen kind of bad complications, especially in patients with, again, not especially. We're talking about patients only with peritoneal surface malignancy, not other situations, right? I'm not anti-radiation or anti-proton. We're talking about this specific topic. So I would, that is kind of my attitude towards that.
We appreciate very much you sharing your experience and opinion. You know, likewise at PNP PALS, our guidance is to just get to the specialist to know the disease, right? In rare instances, from time to time, we hear about radiation, but it's rare. And our guidance is always, we believe you're best to get to one of the trained surgical oncologists. And again, you know, we give our opinions and try and give some guidance, but again, none of us has all the answers. And I think this is part of the beauty of patients understanding that and getting multiple opinions and finding the care team that they're comfortable with is really part of what the Hope Zoom call is all about, us understanding that. So thank you so much for your opinion on that point.
Actually, you know, I just remember there was a point in treatment options for peritoneal surface malignancy when we used radioactive gold infusions in the abdomen. It was popular for ovarian cancer treatments in 80s, 90s, 1980s, 1990s, and we kind of went away from it, this option, extravagant option.
Good.
So maybe going back up to an earlier question in the chat, on, could you talk a little bit more about when is a loop colostomy warranted versus divided colostomy?
Okay, so it's a question about loop colostomy versus end colostomy or end ileostomy and loop ileostomy. We do loop ileostomy because it's easier to connect it back together. So typically when we anticipate that reversal of the ileostomy is in the near future, the beauty of the loop is that you have two pieces of the ileum together, and you can do that through the same ileostomy opening on the abdominal wall. You don't need to reopen the midline incision for that. So you bring up the loop, put it together, and drop it in the abdomen. And it's a procedure hour long typically, and patients go home within 2-3 days when they resume the bowel movements. And ileostomy means that there is another end somewhere in the abdomen. You need to find it. So in order to find it, you need to make more or less sizable incision and find this very end. Make sure that that's the end, not something else. It's a big tragedy to connect something that should not be connected together. You will be surprised, but it's possible and it's relatively easy to do. So again, there's end ileostomy or end colostomy requires typically a big operation, typically through the midline incision. And that's the answer you were looking for.
Okay, and then on the ileostomy, I think you see the question in there. It's a fairly simple procedure to reverse it when it's a temporary ileostomy?
It's a simpler procedure, typically. Again, under 1 hour, and still under general anesthesia, but it is much easier, yeah.
Okay. And then I think back to the small bowel. Is it possible to see if disease is on the small bowel versus the mesentery on a CT?
CT is notorious underestimating the involvement of the small bowel, and actually we use more and more. We use a diagnostic laparoscopy before the surgery, and even on diagnostic laparoscopy, sometimes you cannot. There's so much adhesions that you cannot see the small bowel entirely, all the surface of the small bowel, or all the mesentery. So the short answer is CT might be terrible in estimating the small bowel, and we have a few indirect indications, but we cannot see it clearly.
Okay, and then also on the small bowel, you can see we have a patient that is in a trial where there's a modified cold virus being injected into the tumor. Are you familiar with that trial? And is that, are there any patients that could have that done before surgery?
I'm not familiar with this trial, and most likely it is a trial. It's a phase 1 trial that assesses basically safety of this treatment and a proximal way to administer this drug for maximal efficiency. So I think it's fairly early. That would be my guess. At least I haven't seen it on any recent publication list or during recent conferences.
Okay, thank you. Then could you explain robotic assist and when a patient might be eligible for that?
And actually, I did my robotic assist set reduction last week. I would say it's a lot of fun because you just operate on a robot. It's just, you have full control of all the instruments and the camera. You don't need assistance. It just very precise, and I use minimal invasive techniques only when I know exactly what to remove and there is a low burden of the disease. So if it's not a good, at least in my opinion and in my hands, it's not a good technique when the risk of unexpected findings is high. So robotic and minimally invasive surgeries are good for predictable procedures that you know what are you going to do. With peritoneal surface malignancies, sometimes you don't know what you're going to do. Maybe we'll resect this organ or that organ. We'll try to save this and that. We may spend 4 or 14 hours in surgery. So it's a lot of uncertainty, and I don't like using minimal invasive techniques and uncertainty, and kind of booking all the robot for the whole day. It's not kind of sometimes feasible.
Thank you.
But it's a lot of fun to do for the surgeon.
I had the opportunity at the training center here at UCSD to use a Da Vinci machine and thread a needle. It was amazing to drive that machine. Astonishing. Yeah. So I see another question here about lungs. Did I miss that?
Was next on my list.
Okay.
Go ahead.
Okay. Yep. So we have a question. Have you heard of HIPEC in the thoracic area? I'm scheduled to see a thoracic surgeon at MD Anderson for possible surgery, resection, debulking with HIPEC. And I do think this is a patient, if I'm correct, Carla, there's a lung nodule of PMP. And so I know, right, there's thoracic cavity, then there's lung nodule. Maybe you take a minute to talk about both.
Yeah, actually, we have paper in publication on thoracic, it's called HITEC. Right, yes, we do this not routinely, but about 2 or 3 cases a year, and that's the principles of surgery or the surgery are the same. You remove all visible disease and leave as many organs as possible. As thoracic surgeons say, there are not too many organs in the thoracic cavity, just lungs, heart, and esophagus. How can you go wrong? So, but yeah, we do this on our patients, and we actually summarized our preparing our experience for publications, and it's definitely something that could be done for patients with disease in the thoracic cavity.
Good.
Okay. What advice could you give to a patient that has had CRS HIPEC and is on chemo, and the effects of the chemo are quite debilitating?
So it all depends on the situation, what disease process we're talking about. So for patients with appendix tumors, for low-grade tumors, there's no good data to suggest that it's helpful, and I routinely strongly advise against additional chemotherapy. For high-grade tumors, there is also not very good clear data about chemotherapy after the surgery. But we're more likely to advise to go through that kind of as we do with colon cancer patients. So not for good reasons, but we do advise to undergo surgery. But it means that it's a soft call. Whenever there is a soft call, there's no data, clear data for it. I tell for the patient, it means that if there are side effects that interfere with your lifestyle, it means that don't be afraid to tell your medical oncologist about it and discuss whether you need this additional treatment or not, because it's not like required. It's not the situation when okay, what are you doing? Are you going to be dead if you don't do this chemotherapy? That's very far from reality. We recommend it only on the grounds of similarity with other situations. And if we were clear that it's a clear winner, we would have said so. I think it's for the patients, my advice is not to like stop or continue. That's not what I'm advising. I'm advising to set, first of all, talk to your medical oncologist about the side effects, and for yourself, set limits, what side effects you are willing to tolerate, what side effects you are not. For example, if I were a patient on Folfox, for example, I would say, you know what, that's not for me. I cannot stop playing piano for me. That's what I like to do. I would rather have diarrhea and be go to the bathroom like 5-6 times a day. That's fine with me, but I cannot have neuropathy. I'm sorry. So that's kind of sets very good limits for the medical oncologist, and second, make him question or her question what indication, what evidence do you have when you advise this or that. If the indications are soft, don't feel obligated that you have to go through that.
I think this is an incredibly important point. So many of our patients, and as we speak to the audience, we hear local surgeons say, I've scheduled you next week, we're going to do cytoreduction. And our advice and guidance is always, seek care from the specialist surgical oncologists. We have them listed on pmppals.net on the Find a Surgeon page, but it's really important you seek a specialist. Likewise, we have medical oncologists routinely say, here's the treatment I would give you for your disease. We're going to start that on Tuesday. Especially in America, we want you to understand those are choices that you have in your care. And it doesn't mean that's your only choice or even a choice that's right for you. So Dr. Gushchin's advice is very, very wise right here. So we should seek multiple opinions to get the advice that's right for us. In my personal journey, and many of us have this in our journey, I was told by incredibly reputable West Coast hospitals that I had maybe a year to live. That was 16 years ago. And those were medical oncologists, right? And I was very grateful to find PMP Pals on the web. My father actually found it. And that started my journey and got me to care and visiting a bunch of different centers. So please seek multiple opinions. Dr. Gushchin, does Mandy collect records for you too? If patients are interested in consulting with you after this, can we help make those connections with Mandy?
Absolutely.
And
absolutely.
we'd be happy to do that. So that would be terrific. And
yeah, I think we've got 2 more written questions, and then we'll see what else happens. So so one question is just more of a holistic question, but is there anything diet-wise or lifestyle-wise that potentially could prevent recurrence in a patient that's had a successful CRS HIPEC?
It's a tough one because I don't have a direct answer. We do collaborate with the institution on the West Coast about holistic approach in patients who had HIPEC, CRS HIPEC, to manage their symptoms, to prevent recurrence. It's a very difficult field to do research on. There's so many things to control for, and it's incredibly difficult. It doesn't mean that we give up on this, but I'm trying to say that I'm not against it, but it's a hell of a job to research it, and I cannot recommend just because I think that something is better. So having said that, I think the patients are much better. To prevent recurrence, the short answer is no. There is no data to suggest one way or the other. I think that patients are a very good resource for themselves and for others to tell the tricks how to cope with either consequence of CRS HIPEC or chemotherapy. We can give diet advice, but to be honest with you, patients are more frequently spot on than the surgeons about diet advice, and that's my experience, to be honest with you. So what I usually do, my trick is when I have this specific question from the patient, I sit down and ask what works for you, what not. And in the 20-minute conversation, it becomes very clear what helps with diarrhea, for example, or heartburn. And I just repeat this advice back to the patient. So that's my trick. But a serious takeaway message is that there are multiple ways to do that, and typically it's the patients who we can certainly help with, like medications, but there are so many ways to either Imodium or Metamucil or something else. We can recommend that, but what exactly works for this particular patient, that's patients are usually very good at figuring out, and if I can help it to bring it up, I will.
Thank you. And then just want to make sure, and we're back to the mesentery and small bowel, the question, can the mesentery have disease involvement and not the small bowel, or is
absolutely
it
yes.
Okay.
Yeah, absolutely yes. And it's an ongoing project in our research group. We see which patterns of involvement of the mesentery and small bowel characteristic of certain types of tumors, and what can we do about it, and what the prognosis, what significance of it is. Yes, but the question is very good. Yeah.
Okay, thank you. Those are all the written questions I see, but if there's something maybe that somebody really has a burning question, maybe wave your hand. Kelly.
Kelly, hold on. I gotta find you. I saw you for a second. There she is. There we go. Hold on. You see a magic button there? There's my girl.
Can you hear me now?
Hi,
Okay.
Kelly.
Yes.
Hi. Thank you, Dr. Gushchin. This has been very informative. I really appreciate your time. I am in the process of getting a consultation with Dr. Sardi. And I'm curious because I have not met him in person yet, do you two regularly consult together on patients or candidates for surgery, or even come in with a multidisciplinary team during the surgery, depending on what is called for?
Well, we were part of the so-called Chicago consensus that pushed for 100% discussion of all patients in a multidisciplinary fashion, because I think it's extra important. So we do that formally. But most importantly, we do this informally about 20-25 times a day. So either he interrupts me in the clinic, or I interrupt, I do the same day or night. And we do that in the operating room too. We scrub into each other's cases. Believe it or not, we do that not for technical expertise. I'm not sure that he can not do something that I can, and vice versa, but to make a decision. I think that's the most difficult part in peritoneal surface malignancies. And I think that's why the level of cooperation, not 100%, but 200%. Because we discuss patients not once or twice, but like constantly. And we do that not because there is great uncertainty in the area. What can I say? Again, I'm not proud of it. It's not the good. It would be much easier situation when nobody consult anyone because it's clear what to do. But unfortunately, it's not the case.
We can certainly vouch for the collaboration between these specialists. Adele and I have had the pleasure, and Charmaine as well, and many of us on this call have had the pleasure of attending the annual symposia with our surgical oncologist specialists. And the collaboration, communication, engagement between them is unparalleled, in my opinion, in medicine. I think it's truly amazing. And yeah, we see them collaborate all the time, so we appreciate that. I know the team in Baltimore pretty well too. I've been going back there almost every year for the Heated to Beat It event, where the team raises money for research, and it's an incredible event. And yeah, so a great team for sure.
The key during this conversations or collaboration is to argue with each other. So when you hear us, we're like going at each other, and the reason is there is no reason to consult if you agree with everything. It's kind of zero value. So you actually have to present different points of view and be ready to defend it or to look at to another opinion. So that's how kind of we do that. So from the side, it looks very confrontational, but we kind of, I think that's kind of our style.
Great, thank you. Charmaine.
Charmaine.
I don't know where I am. I guess I'm up there. I just wanted to say one thing that an earlier comment made me think of. As we go through these calls every week, a lot of times I hear questions addressed to our group that I'm thinking, why isn't that person asking the surgeon or the medical oncologist? And I think that one thing that you said about really probing why your medical oncologist is recommending chemo is really important. And I just want to use that to encourage everybody to go back to your doctor and ask the questions again. I think what happens a lot of times is we get home, we think about it, maybe we do some reading, and then we realize we don't really fully understand the reason. Or is this, well, let's try this, or is this something really that the physician is saying, this is the way you need to go on the treatment for your particular condition. And I just think that all of us really need to be prepared to go back a second time or third time, whether through an email or a telephone call or another visit, to handle those follow-up questions, because you know, I think we hear the doctor's recommended treatment a certain way. We think it's kind of, we would be crazy not to do it. But just from the comments today, it's pretty clear that sometimes, you know, it's, I don't know, what did you call it? Semi-voodoo or something? maybe not necessarily as strong a reason to pursue a particular course of action, especially if there are a lot of side effects. So I guess the bottom line is, you know, patients, we just have to go back a second, third, fourth time, whatever it takes to make sure we fully understand the reason behind the recommendation.
This is incredible advice, Charmaine. Thank you for the reminder. You know, there's two aspects of us. There's the physical aspect, and Dr. Gushchin is an expert in treating that aspect of us. There's the emotional aspect too, and I think what Charmaine is saying is, even though physically we've been betrayed by our gut, emotionally we have to trust our gut, right? So if you're not clear, you're not sure, then you should be asking more questions and getting multiple opinions. And so that's spot on advice, Charmaine. Well, with that, I'm going to say, Dr. Gushchin, thank you very, very much for being here. We very much appreciate your expertise and are grateful for your time. And thanks for taking the time.
Yes, thank
you very much. You're correct. It was fun.
That's great. Well, now we are going to do something a little special today, and I'm going to invite you, Dr. Gushchin, to stay and participate. But the emotional journey we find is equal, if not more difficult than the physical journey. And so we are going to take some time and go around the horn and check in with a couple patients, because we've got some important updates to check on. But I will also remind everyone, including Dr. Gushchin, if you have other things you've got to go do, don't be shy. Go ahead and take care of those things. Take care of yourself in this time of your greatest need. But I will remind folks as we wrap up that you can stay connected with us at pnppals.net. We have lots of information there, including a Google map that shows the experts around the world that you can rely on. You can see events and positive information posted on our Facebook page, and our marketing partner, Jen, will share lots of encouraging, inspiring messages on Instagram. So you're welcome to follow us there, and we hope to see you there. And with that, we will conclude the physician portion of the conversation. And again, Dr. Gushchin, you're welcome to listen in, and I think you'll appreciate what you see here and learn here today if you want to stay on. But why don't we go around the horn and check in on some of our pals and see how people are doing. We've had some doctor's visits, and we might have some other questions, but let's have some emotional support for one another.
Yeah, so maybe we could start with Anne, who did have her follow-up appointment yesterday.
Anne, I sent you an email if you didn't get it. I sent it at noon yesterday.
So sorry, I was so tired last night. I actually slept, so
yay.
Yay, it was great. The appointment went well. I had a great, actually, obviously sense of humor is very important to me. So when I went to Moffitt, my first test was the CAT scan. And so the person who did the scan, great personality. We got along great. And, you know, you go in before the contrast and you're like, you know, Jacob, please do me a favor. Don't find any cancer. And, you know, right away he's like, this rating, I'm going to be like Stevie Wonder. I'm not going to see a thing. So, you know, it's just that type of rapport that patients really need. And Stevie Wonder did not find anything. So, it was good. They did not have my CAT scan completed in time for the report with Dr. Deneen, but he went through it and he compared. Everything looks good with the exception of the only concerning thing is cyst growth on my ovaries. But my tumor markers, thank you, Adele. Thank you so much for reminding me about that. We're in the normal range. So he's not concerned with that. He is having me come back to get those looked at and to see if there is any concern, but he doesn't, because of the tumor markers, he doesn't think it's anything to do with appendix cancer. He just thinks it's something regarding women my age. So yeah, so that was a big relief. So yeah, I was able to finally sleep last night. And so yeah, I will see him now instead of 3 months, in 6 months. So 2021 will hopefully be a better year. Yes. So yeah, I'm going to make another trip down to Tampa. My husband said, well, why don't we just do it in Ocala? And I was like, no. We're going back to Moffitt. I'm going back to Moffitt. And Dr. Deneen said, absolutely, come back to me. Not to him, but come back to Moffitt. Get it checked out. He'd rather have someone at Moffitt do it. Because, you know, obviously I'm not living in Ocala. So I will go back. I should get an appointment, not next week, but scheduled next week. He was just putting the orders in just to make sure. He'd rather, you know, obviously play it safe with me. So he put me at ease. He was trying to explain to my husband how this cancer is so rare, and you really need to know, you know, what you're doing. And so, you know, my husband got schooled and I loved it. So, so he said, essentially I'm NED. You know, he just wants to make sure that the sister, you know, just to keep an eye on those. That's the biggest thing. But, you know, tumor markers were great, so he wasn't really too concerned.
That's great.
We're happy for you.
Yeah, yes. So, yeah, I broke that to my boss on the way home in text. I'm like, oh, gosh, I can't get off of work. I guess I'll be back on Monday. So, yes, she was thrilled. So, yeah, I'm back to hopefully getting a solid 6 hours a night without worry and looking up everything on on Google, I should say. So. No, it was good. Thanks for all the well wishes from everyone. My texts were lit up yesterday. I was at Moffitt and it was just one after the other, and I felt so loved. So thank you all for everything and the well wishes and the prayers, and they helped. They really, really helped, and they put me at ease. And so yes, I'm grateful to everyone.
Let's see. Paula, I know you weren't on last week, but we have you slotted first next week, unless there's some more things you'd like to share today.
Yeah, I can share it next week. My biggest thing is and the doctor will understand this, pulling the trigger for a second CRS HIPEC. I had mine in January 2017, and at the time at UPMC, they said, well, we're going to give you in general a good 3 years. Well, I'm over that. I felt well, had no side effect feelings or anything. It's knowing when to do it, how long, because as we know, CTs and even their really strong, wonderful MRI they have up there at UPMC can't really see. They keep saying I'm stable. And since I do have signet ring cell and high grade, it's got to be back. And in fact, my CEA has risen a little bit, and I don't know how much statistically it has to rise before there's a concern. It's probably not very much rise that you have to see, and maybe 3 in a row, as I understand it. I'm not sure. So that's where I am, not knowing. And I would be going to Baltimore, even though I'm more familiar with Pittsburgh. That's okay. I don't know how the COVID things are right now in Baltimore. I know things change all the time. I would hope not to have to quarantine for a long time if I went there, but we'll see when the time comes. And thank you very much, doctor, for all your input.
It's a tough decision, Paula.
It is tough. It is, especially when some very good doctors here in St. Louis keep saying, oh, no. You don't want to do that, because they know all the things that can happen. Mm-hmm. But you have to talk to a surgeon. Mm-hmm. And these are not surgeons. So anyway, it's hard. Thanks very much.
Good to see you smiling. But
thanks. I am always.
And so we're here every Saturday, right? We started an hour later today than we normally do to accommodate Dr. Gushchin's schedule, but we'll be back next week, 11 a.m. Eastern and 8 a.m. Pacific. And I can't forget, see if there's anyone else we need to check in with.
Mayella, how are you?
If she's not there, I would just say I saw on the support group page she may be taking a break, getting a sandwich or something. She went in for her surgery, but they did not allow it to proceed because of the high COVID situation they're experiencing in El Paso. So her surgery's been postponed.
Oh, thanks, Shireen. Let's see, Alan, I think, how are you doing? You have to unmute.
I'm just getting things situated. Hello.
Hello.
I'm almost 8 weeks out from my surgery, and every day it's getting a little better. Just dealing with a little bit of low energy and trying to figure out exactly what I can eat that's not going to cause me, distress in terms of gas and bloating. But I think we're figuring it out slowly.
Well, we're glad you're here.
Thank you.
Rita, how are you feeling?
I'm doing okay. Slowly getting there, but the stomach is still not behaving. But I'm getting stronger day by day. I had Dr. Sardi and Dr. Gushchin on September 3rd. I had surgery with Dr. Sardi. I'm doing okay, but the recovery is taking time. Thank you, guys.
Let's see. Jill, are you doing okay?
Yeah, I am getting ready actually to fly back to Baltimore in early November. So hopefully, last I heard they were taking in-house appointments. So, yeah, I'm suffering a little skin anxiety. I'm now on the Whole30 diet, trying to lose my belly. One question that's come up in my brain is that, I get my CT scan done at UCSF, and then I take it with me. And I always wonder, isn't it the reading of the radiologist that really indicates what they see? And sometimes I wonder, UCSF doesn't do this surgery. Why is it that I'm not being requested to do this CT at Mercy when that radiologist probably does know what he's looking for when he looks, you know what I mean? It's like I drive into the city, I could just go down the street to the local hospital, but I'm like, well, at least I'll go to UCSF. But how important is it, the person reading that CT scan? And, that's, kind of, does that matter who reads it?
Dr. Gushchin?
Thank you for the question. Well, it does not matter where the CT scan is done, because compared to MRI, the technique of CT scan is pretty good right now. I haven't seen a bad CT scan in a long time from the United States. So, but it doesn't matter who reads it. I do not typically rely on radiologists, whether at Mercy or elsewhere. I usually look through the report, definitely, but I look at each and every single CT scan myself, because radiologists may not know the details, and I think that I'm much better than radiologist, any radiologist reading CT for peritoneal surface malignancies, just because of number of CT scans I've read and I've seen, not because I'm a good radiologist, because I may misinterpret something else. So to make it short, it does not matter where you do CT scan. And it is very important for you to bring the CT scans with you, not the reading. So the surgeon who did the surgery would read it.
Well, I do bring it. But I bring it with me, and they, hand it in while you're sitting in the waiting room. And 15 minutes later, I'm seeing Dr. Sardi, and he's in that 15 minutes. Actually, he's usually in with another patient. And so I'm like, really? Like how, like, of course, in my brain, I would like him to be analyzing that for an hour, you know, but in 15 minutes, he's looked at it and actually read it. I mean, one appointment, the radiologist found something that he didn't find. And when I asked him about it on the report, he said, oh, well, let me look at that. So it just plants these seeds of doubt as to, is he really reading my CT scan and giving it the attention that I want him to give it, you know?
So you're bringing, again, very, very good point. I think he does. I mean, it takes about 1 or 2 minutes to go through the CT scan kind of for what we're actually looking for. And again, he would be, it's also important to have a reading from radiologists to pick up something that we're not trained to pick up. So again, I'm not pretending that I'm a trained radiologist, but I'm very good at reading the peritoneal surface malignancy stuff.
Yeah, and I believe that. I mean, I want him to read it. I didn't realize it was that quick to actually
it's pretty quick.
see what you were looking for.
It's pretty quick.
I would like at least 2 hours spent on my CT scan analyzing the minutia of it.
Well, so sometimes we, when we have a question, we actually take it down to radiologists and go for whatever time needed with 1 or 2 radiologists. So not everyone, I wouldn't lie, but with difficult situations, we do that.
So so I don't even have to really go into UCSF. I could go to a local hospital and get it done, and it would be the same thing.
Yeah, I would say yes.
Yeah. But no, I'm doing well. Thank you very much. I'm doing well, just, trying to lose my belly before I get into the appointment so that I know it's just fat, not anything else growing in there.
Great, Jill. Mayela, we see you're unmuted and we heard your surgery got postponed. How are you doing?
Yes, and thank you for filling in for me, because it's exactly what happened. I went in, I was already with my IV, with my gown. I had been sanitized, so mentally I was ready to go. And the doctor wanted to ensure that the hospital was able to secure a private ICU bed for 24 hours at a minimum, right immediately after surgery. And because COVID cases dramatically increased, the hospital could not guarantee it. So he just didn't think it was safe or worth the risk to be out of surgery and be waiting for a private room that might not be available, and did not want to have me in the middle of COVID patients. I felt like he made the right choice, so I'd rather it be rescheduled than, be exposed to COVID.
That's hard. That's incredibly hard. But it sounds like the safe decision to make. So we can only imagine how disappointing that was. But I'm glad you're here to talk about it, Mayela. Yep.
Absolutely. Cheryl, how are you?
I'm doing really well. Received my scans a week ago. Even though my CEA number, CA19-9, is increasing slightly, that they weren't concerned because the CT scan was showing improvement in areas around the small bowel. I have signet cell undifferentiated, but also a complete cytoreduction score of 0. So NED right now, but I still get that anxiety. I love that Charmaine brought up about probing and asking questions, because I think only now, it's been taking me almost a year to really start, and this group, to get me to start questioning. And I'm in the same boat as Paula. I like the idea of doing something. So if they would give me chemo right now, just in case, I would take it. I am on Avastin right now, and I'm starting to question the necessity of that, but that'll be my appointment Monday. So I'm doing great. I have processed the good news, and that took me about a week to do that. I do have shingles. That came up quick last week, but the pain so far, it was 1 week. The rash showed up, but I haven't experienced pain yet. So fingers crossed on that, but I'm doing fabulously. So
You sound great. You look
Thank
great.
you.
That's terrific. Thank you for being here to share that positive energy with everybody. Yep. So can I check in on Kevin? How are you, Kevin? We don't see you every week, but it's great to see you, man. How you doing?
Yeah, hi everyone. I'm doing well. I just had I saw the results of my CT scan from last week, and as a reminder, I have a low grade with metastasis to my lungs, and they kind of feel like what's on my lungs is a little bit of a higher grade, and we've seen more fluctuation in terms of spots appearing and disappearing in my lung areas. And I switched to Fulfary back at the end of July. And I know that, there's always, the debate about whether or not chemo works for low grade or not. But my CEA numbers are still pretty high, but since July, they have gone from 1,100 down to like 595. Mm-hmm. So, of course, I know that you never really know exactly what everything that's going on when you see the CEA numbers change. But from looking at the CT scans, they say that things still appear to be stable. So I've been doing well, feeling well, and having no physical complaints at all.
Good, man. It's good to see you. Thank you for checking in, and happy to have any news shared, right? We don't expect people to come here with good news and just share the good stories. We're here to hold even the bad news and support you and be with you if there's tough times too. So we're happy to do that because we think that's an important part of the process to feeling better and getting emotionally healthy too. So it is so good to see everybody. We are coming up to the top of the hour here, so I'm going to call it for the week. But we will be here next week, next Saturday. We'll be excited to see everyone. Thank you for being here again. Oh, I almost forgot. Thank you. And next week, don't forget, we're going to be dressed up in Halloween costumes because we're going to have a little fun and make the best of a bad situation. So we're looking forward to seeing you, and we can't wait to see your costumes. And if you can't wear a costume, you can make a pumpkin. You can carve a pumpkin. We want to see carved pumpkins. We want to see Halloween spirit next Saturday. So thanks, everybody. Have a great week.
Thank you, everybody. Bye.